Yesterday, we ended on babies being born. I told you my entertaining / horrific story of when I had a baby. Once the baby is born, the next thing that needs to happen in terms of our notes here is the baby needs to eat something. And they need to eat something pretty soon because they're no longer attached to mom and they can't get nutrients through the placenta anymore. So lactation is the last sort of piece of the puzzle in terms of the baby. Of course, things happen after this, but we're not going to follow the baby through development after it's born. This is really the only after the baby is born thing that we're going to discuss. Now this diagram comes out of the textbook, and if you look, it's a circle, so there's really not a beginning and an end to this pathway, and it works in sort of a cyclic fashion until you take one piece of the cycle away. So typically, here's what's going on. Oxytocin is being produced. It's being produced already because if you recall, that was the hormone that made the uterus contract to help give birth to the baby in the first place. But oxytocin doesn't only do that. It also plays a role in lactation. Now, when the baby is born, one of the first things the nurses will do is try to get the baby to latch. That means try to get the baby to latch onto the mother's nipples so that it can start feeding. Okay? It's sort of the first thing you need to get the baby to do, because if the baby can't do that, then it can't eat, right? And eating is very important. So typically, here's what will happen. The nursing baby stimulates neurons, specifically sensory neurons, in the nipple and areola, and the areola is like the area around the nipple. So there are sensory neurons there that are going to be stimulated just by a baby latching on. Then this stimulus arrives at the hypothalamus, so follow a pathway to the hypothalamus. The hypothalamus will then stimulate the posterior pituitary to secrete oxytocin. And perhaps you remember that oxytocin is one of those two kind of weird ones that's made in the hypothalamus, but then just released by the posterior pituitary. Oxytocin causes mammary lobules, so these little structures that have milk inside of them to contract, and the milk is ejected. That is the loop through which breastfeeding can happen. There's another hormone called prolactin that comes from the anterior pituitary that stimulates the production of milk, so actually making milk, but oxytocin stimulates the ejection of milk. So there are two parts to it. You have to be producing milk, but the milk also has to be ejected. What this means is that if you keep this pathway continuous, a mother could breastfeed for really any length of time that she so desires. As long as this pathway is maintained, breastfeeding can continue. Now, what's typical is during the first year of life, maybe less, depends on what the mother's scenario is, but that's pretty normal for people to breastfeed for that amount of time. Most doctors will say that for at least 6 months, that's what you should be doing, because babies can't handle solid food. But there's also the option to provide formula, which will have the same basic things that breast milk has. It's really hard to completely mimic breast milk, but technology has come really far, and like it's pretty close. There are people though who choose to breastfeed for much longer than that. When their children are several years old, they are still capable of doing it as long as this pathway hasn't been broken. Anyone want to have or ask any questions about that? So, the last thing we need to cover is a little bit about sterility, infertility, and reproductive technologies. Now, we kind of skipped over the part where we look at individual STIs, but you don't need to memorize the detail of any one STI. An STI stands for sexually transmitted infection. And there are many. Some of the ones you might have heard of are things like HIV, HPV, syphilis, gonorrhea, herpes. These are probably things that you're like, yeah, okay, I've heard of that before. And I'm not expecting that you know the specific details of any one of those things. But what will happen on the game that we'll play in place of the Unit 4 test and the actual final that you will do at the end of the year, is that if I want to ask you about an STI, I'll tell you what some of the symptoms are, and then ask you to relate that to reproduction. So for example, an STI could affect the passage of the egg. Many STIs will cause fallopian tube scarring, because they cause inflammation or irritation to that tissue. And so that's a pretty common thing. A lot of STIs will cause fallopian tube scarring, and that will lead to issues with the egg getting from the ovary to the uterus. So even if the egg is ovulated, even if the egg is fertilized, it can't get where it needs to go. Sometimes STIs will affect the passage of sperm. So this could be issues with the epididymis or the vas deferens, or sometimes the urethra having scarring. So tissue has been damaged in one of those areas. And so a lot of STIs will have one of those effects. They'll affect the way either the egg gets from the ovary to the uterus, or the way the sperm gets from the testes outside of the male's body. And then an STI that a female has could inadvertently affect the passage of sperm as well, because if she's got scarring in her fallopian tube, that might mean the sperm can't even get to where the egg is. Now the third thing that a lot of STIs do is they'll affect the possibility for implantation, specifically because they're affecting the endometrial lining. So this is where there is uterine scarring. So some STIs will cause damage to the tissue of the uterus itself. And if the lining of the uterus has scars on it or is damaged, then it might be impossible for a fertilized egg to implant itself there. Now, do you have to know which sexually transmitted infection does each of these things? No, I would tell you that in a question. But if I said, hey, the sexually transmitted infection, PID, pelvic inflammatory disease, which is one of them, causes fallopian tube scarring, could you tell me that that might affect the passage of the egg? Could you find the fallopian tubes on a picture or on a diagram? That's the kind of thing that you have to be able to do. So not memorize the details for each one of them, but if we tell you about it, to identify which parts of the reproductive system that goes with. Does anyone want to ask something there? Yeah.
I'm just curious. So why did they change it to STI? It used to be STD, right?
Because the word disease has different connotations than the word infection. Sometimes I don't know what the real push was there, but a disease is more encompassing, I guess, and an infection is something. Oh, I'm gonna trip over my words here. A disease can be more things than an infection, right? You can have other diseases that are of different types, whereas an infection is a biological medical thing, and that's what we were trying to cover with that description. Now, there are some technologies that can be used. I've told you about a few technologies that go along with the baby itself, like chorionic villus sampling, amniocentesis, or ultrasounds. These last two things are some technologies that could help either improve or make worse someone's sterility. Sometimes people do not want to have children, and so they would prefer to be sterile or to be unable to have children. For other people, it's the other way around. They're having issues, and they would like for it to be easier. So I'm giving you 4 examples of technologies or strategies that a person could use if they were having issues with fertility. Now, I'd just like to say I am in no way advocating that you do any or all of these. I'm just telling you what they are. The first one is in vitro fertilization, which is probably the most commonly discussed one. That's a medical procedure whereby an egg is fertilized by a sperm in a test tube or in a petri dish or somewhere else outside the body. In vitro means like in the glass fertilization. So take the sperm, take the egg, put them together somewhere else, and then later on they will be implanted into somebody's uterus. Artificial insemination is a similar process, but that is where we're not going to take the egg out of the woman's body. The woman's going to ovulate her own egg, but we're just going to inject semen into the vagina or uterus that has been removed from the male's body, probably at an earlier point in time. Now, I don't know if any of you guys watched this Jane the Virgin show on TV, but that is what happened to Jane the Virgin. Okay, she went to the doctor to get, I forget what she was actually having done. Maybe she was getting a pap smear or something like that, which is a routine medical test that you would have for female reproductive health. And the doctor was really tired, and instead of doing her pap, injected her with somebody else's semen, and this is how she became pregnant. The third thing on the list is the idea of a surrogate. So it's not really a technology, it's a strategy. Sometimes people will ask a woman who is not the biological mother to carry their child for them. Now, how a surrogate works can be different. A lot of the time it will be through in vitro fertilization. So like these two will go together. Two people who would like to have a biological child of their own, but maybe mom cannot physically carry a baby or something to that effect. They might do in vitro and then have their fertilized egg implanted in a different woman's body, and then she's going to carry the baby, give birth to the baby, and then give the baby to their biological parents. Now, if you watch Friends, this is what Phoebe did for her brother, and then she had triplets. Now, sometimes the surrogate will also be an egg donor. That's a thing too, where she'll provide the egg, and then the biological parents are just providing the sperm. Superovulation is something that often goes along with in vitro fertilization as well. For in vitro fertilization to work, typically what they'll do is harvest multiple eggs from the same mom and fertilize multiple eggs. So you have several embryos in the hopes that at least one of them will implant themselves. So they'll use some drugs to produce multiple eggs. Essentially, they'll up her doses of reproductive hormones to stimulate multiple ova to become mature at the same time, so that when she ovulates, instead of there being only one egg, maybe there's 4 or 5 or 6 or 7 that are coming out. So it's pretty common in vitro for this to happen. So normally they would get the woman on this sort of hormone cycle for a couple of months prior, then harvest her eggs, then do the in vitro. Because normally a woman ovulates just 1 egg per cycle. Yes?
What if you're a woman who do this and have like 8 children?
Yeah, so this is, a lot of these TV shows you see where people have like that John and Kate +8 show, I don't know if that's still something you've heard of, but they were doing assisted reproductive techniques, which is why she had sextuplets, and then she had twins, I think, before that. But a lot of, especially more recent multiple births, are the result of reproductive technologies. There have been people who have had multiples in high numbers naturally prior to that, but it's not a super common thing for sure. Anybody else want to ask anything there? I don't know, guys, I had 1 human baby, and like that was enough. Like there was no more space for any other people in there. Cool. And then I know 2 sets of triplets. I don't know any quadruplets though. Does anyone know quadruplets? I mean, I've heard of them. I know they exist. Yeah. Now the other side of the story would be technologies or strategies which would reduce a person's reproductive capacity, so cause them to be infertile or cause them to be sterile. Sterile means you can't have kids at all. Infertile means it's hard to have kids. Abstinence is the first one, and it's the easiest one. If you don't do anything that involves sexual activity, then there should be no chance for sperm and an egg to ever come into contact. The next one on the list is surgical sterilization, and I put two examples. A tubal ligation is for females. It's fairly invasive because you have to go into the abdomen, find the fallopian tubes, and tie them up. A vasectomy is a lot less invasive because the testes are on the outside of the body, and so you can get at the vas deferens without doing a procedure where the person has to be knocked out. It can be local anesthetic. You can do it as an outpatient procedure where you go, have your vasectomy, and then leave, which would explain why it tends to be the more popular choice for people who are looking in that neighborhood. Lots of people don't ever choose one of these, but if people are looking to prevent themselves from having more children, these are some options that they have. Pretty common one for women to use is hormonal contraception, and there's so many examples of how this exists now. There's the pill, the patch, the ring. They all have the same basic premise. They all contain a small amount of man-made estrogen and progestin hormones, so progestin is in the same chemical class as progesterone. They work to inhibit the menstrual cycle because they're providing negative feedback on FSH and LH, so they stop the woman from ovulating. Now, there's lots of different types of hormonal contraception, and some of them work differently than others. So what I did there was just put what they all have in common. That's how they all tend to work. Does anyone have questions about that? Yeah.
For the surgical sterilization, for the first one, I'm not even going to try to say it.
Tubal ligation, yeah, and a vasectomy.
Thank you. For the tubal ligation, does the woman who had that stop having her period afterwards?
No. All that's happening if you have a tubal ligation is that now, since the fallopian tube is tied, the egg could never make it to the uterus, and the sperm should not be able to find any egg. So we're cutting off the pathway. It's the same with a vasectomy. A vasectomy does not affect testosterone production because we're not really changing the hormone pathway. We're just stopping the pathway that sperm would go through. So a man would still make hormones in normal quantities. Same thing, a woman who had a tubal ligation only should still make hormones in normal quantities. There's another procedure, maybe I'll just mention it, it's called a hysterectomy. In a hysterectomy, depending on the severity of it, sometimes it'll be just the uterus, sometimes it'll be ovaries and uterus that are removed. That's a pretty extreme procedure that's usually done for the health of the woman rather than a preventing reproduction strategy. In that case, then yeah, she would not have her period anymore.
Why would someone get hysterectomy?
Sometimes it's because of damage or just general poor health of the uterus. Maybe there's a lot of inflammation, that kind of thing. But it's not the number one, like it wouldn't be like, oh, you don't want to have kids anymore, let's take out your uterus. Like that's the last resort. The last one on my list here are physical or chemical barriers. So these are probably the least technological of all of the methods other than abstinence. There's spermicide. That's a type of contraceptive that you would apply externally to immobilize or kill sperm before they enter the uterus. Spermicide can be used alone or frequently along with a barrier method. A barrier method would be something like a condom or a diaphragm. Any sort of structure that's usually made out of some kind of rubber or rubber type substance to prevent sperm from getting from one location to the other. Condom would be something that the male would use. A diaphragm would be something the female would use, so would a cervical cap. But they all have the same basic premise. They're like a rubber or rubber-ish type barrier that prevents sperm from passing. Now,